So today we have Sally in our anesthesia procedure. She's having a routine spay. She is 10 months old. She's 25 pounds. She is intact female. Her PE, her temperature was 100.9. Her heart rate was 120 beats per minute. And her respirations was 20 respirations per minute. Her mucous membranes were pink and moist, and her CRT was less than 2 seconds. I converted her pounds to 11.4 kilograms. So I have done all the calculations. So for the pre-meds for ACE, you would get 0.07 milliliters. For atropine, it's 0.42 milliliters. And for bup, it is 0.38 milliliters. And then the adduction, we got 4.6 milliliters. And then for the post-op, the Onsior injectable, we would give sub-Q before we start surgery. It's 1.1 milliliters. And then the Onsior oral, so after pain meds, it would be 1 tablet by mouth. And then the manual drip rate, I got 1 GTT per 2 seconds. And then the PRI is 144 milliliters per hour. And then the VTBI is 57 milliliters per 30 minutes and 114 milliliters per 60 minutes. We would use a rebreathing circuit, and you would use a 1 ml rebreathing bag. There's my math. So once we got all that calculated, we would set up the anesthesia machine. So for starters, you would go to the oxygen room, make sure the oxygen is on, make sure the tanks read above 500 psi. If they're below 500 psi, you need to get help to change them. Check the pressure reducing valve to make sure it is reading 50 psi to make sure gas pressure is being reduced. And then you would go back to your anesthesia machine. You would turn on the oxygen flow meter to 1.5 liters per minute. Verify smoothness of operation and stability of the indicator ball position at 1.5 liter per minute. You would turn off the flow meter and make sure ball returns to 0. Then you would move on to the vaporizer. You would check liquid level. You would fill with correct liquid as necessary. We would use isoflurane for this, so we would check the level in that. And then you would tighten the filter cap, and then you would move on to the CO2 absorber. So with the CO2 absorber, you're going to check the color of the crystals that are in it. If it's a purple color, that means that they're exhausted and they need to be changed. Another way that you can also check it, if they're not purple, is grab a piece, and if it crumbles easily, then it does not need to be changed. Now, if you can't crumble it in your hand, then it needs to be changed because they are exhausted. And then after that, I would go to the scavenger system and I would weigh the F-Air canister to make sure that it hasn't gained 50 pounds or more. If it has gained 50, well, it's not pounds, it's grams, my bad, then it is expired and you need to get a new one. And then after that, I would check the system for leaks. By doing this, I would close off the pop-off valve, occlude patient's Y-piece with the palm of my hand, fill system with oxygen using the O2 flush valve until the circle manometer reads 30 centimeters H2O. Pressure should not decline more than 10 centimeters H2O in 30 seconds, and then you would open pop-off valve to release the pressure. And if you find leaks, try to find the source of them and recheck it to make sure that the system is working. To check the pop-off valve and scavenger system, you would open the pop-off valve, occlude patient Y-piece, turn oxygen flow meter to 4 liters per minute. The circle pressure manometer should read 2 centimeters H2O or less at this flow rate. If it increases, then something is keeping the scavenger system from working properly, which that can affect your patient being on anesthesia. It can cause serious problems because they're not getting the right amount of oxygen that they need. So after doing that, there's some other equipment that I would grab so it's ready to go, so we can quickly get this patient under anesthesia, quickly do the spay, and then get the patient recovering. So some other equipment that I would use is I would get the clippers ready, the prep materials like gauze, alcohol, chlorhexidine scrub, catheter materials, the medications. I would draw them up, get them ready, mix them so they're ready to go. Turn on the surgical prep table, turn on the surgical OR table so it gets heated up. Get out a thermometer, stethoscope, ET tube that correctly fits the patient, tube tie, gauze, like I said before, laryngoscope, syringe to inflate cuff, eye ointment, some type of warming device in the recovery cage, surgical packs, drapes, scalpel blades, gowns, gloves, table ties, Betroth, hand brushes to scrub your hands before you get ready for surgery. I would also have the ECG ready, the pulse ox ready, all that sort of stuff, so that way it's ready to go. So as soon as we hit that OR table, we can get them all hooked up and ready to go. And then, so we have all of our equipment set up, and we got all of our medications on board, all that other stuff. So now we have elected to do a saphenous catheter. So what we need to get ready is a 23 gauge catheter, which I have right here. Tape, which you can tape it in. Injection cap, scrub, alcohol, clippers, flush, extension set. Okay, so we are going to go get Sally, and then we will show you how to do a saphenous catheter. You can put Sally down. Okay, so the saphenous vein is actually in the back leg. Do you mind just holding his head?
Yeah.
So what you're going to do is you're going to start down low on the leg. And then you're going to, if you can't get it on the lower leg and you can't get it into the vein, you're going to actually go higher up. But you want to start on the leg down lower, so that way if you miss the vein, you don't have to worry about going up. You don't have to worry about going down and having blood come out of the beginning part. So we're going to clip the leg. Okay, so the vein is actually right here. So what we're going to do is we're going to grab some Chlorhex scrub and some alcohol. We're going to put the alcohol on it, wipe it down, good to go. And then you're going to insert the catheter, and then you're going to advance just the stylet. You're going to push the stylet off the catheter. And then once catheter is fully in the vein, you remove the stylet, you place the injection port onto the catheter hub, and then you tape it in without letting go of the leg, because if you let go of the leg, the catheter is going to move. So then you're going to tape it in, and then you're going to flush the catheter to make sure that the placement is correct. Make sure you do not draw blood back into the flush syringe. And that's how you place a saphenous catheter. You're good to go now. Until the next one. So, we put Sally back. Well, Sally's down on the floor. So, next we're going to talk about intubation. So, with intubation, you are going to give pre-meds first, then give it about 20 minutes or so for them to kick in and work. And then while you're waiting for that, you pretty much draw up, or you prepare the rest of your stuff. So once you're done with that, you're going to place the IV catheter, which we placed a saphenous catheter, so we would use that. And after we get the saphenous catheter in, we're going to slowly push the propofol through the IV catheter, so that way the patient will become even more sleepier than normal. And then once that's done, you're going to slowly administer it, obviously, and then you're going to pay attention to the patient's jaw tone. The jaw tone is important because you need to make sure that it's not there, because if it's there, the patient is going to be more resistant to intubation. So once jaw tone is barely there, then you can intubate. You need the gag swallow reflex to be gone for successful intubation. You can intubate at stage 3, plane 1. Supplies that you need are gauze, tape, gauze, tube, your ET tube, cuff syringe, laryngoscope, light source. You want to watch for signs suggesting you are in the right spot, such as coughing. It doesn't always occur, but it's definitely a sign. Fogging of the ET tube or moisture accumulation in the tube. Air movement you can feel at the end of the tube. Palpation, you should feel only one tube in the ventral cervical area. And movement of the rebreathing bag. So attaching your patient, so once the tube is placed, attach the Y piece to the end of the tube and turn the ISO to 5% and the oxygen to 1.5 liters per minute. Keep an eye on the patient and watch as they go through the different stages and planes. Once you notice your patient is in stage 3, plane 2, you can reduce the ISO to 2.5 and closely monitor your patient to watch to see if they are too deep or too light. So after intubation, your patient is now under anesthesia. So we're going to prep the patient both outside and inside of the OR. So to prep the patient outside of OR, the hair removal, you want to position the patient in the same position as the surgery. So they're going to be laying on their back with their arms up so you can get to their stomach. You want to ensure patient is at a stable anesthetic plane before starting, because this is where they can start breathing heavily and it can cause problems. So the area to clip, you want to be neat and symmetrical, which is important because people pay attention to how well the cutting is. You want to use a 40-inch blade. Hold flat against patient's skin to get close, and it also prevents razor burn. The hand not holding clippers, you want to stretch skin for easier removal. You want to remove about 2 clipper blade widths in every direction of the proposed surgical site. It's also important to ask your surgeon if that's a good area and that if they want more or less taken off. And then next you're going to scrub the site. So you're going to use a target pattern, which is where you place gauze in the center and wipe gently in a clockwise pattern with every circle a little bigger, and then you're going to have a small overlap of each circle to make sure all skin is covered. You're going to use chlorhexidine scrub, then alcohol. You're going to do this 2 more times for a total of 3 scrubs. Then you would unhook the patient and carry the patient to the OR. When carrying the patient, you want to make sure that the clean site does not touch you or any other body part of the animal. So basically, you're going to scoop underneath them and carry them like a baby in a way. So once you get into the OR, that's your sterile environment. You're going to hook the patient back up and place the patient on the table as the surgery would need. You're going to tie the legs up and be doing the final scrub. You're going to use dedicated scrub and alcohol from the surgical site or the surgical suite. They are specific to that suite. You're going to use the target pattern again. Once the scrub is done, you basically paint an application of iodine on the incision site. Oh my god, I cannot talk today. And you're going to basically be all prepared to start the surgery. And that's when the doctor or surgeon is going to put the drapes on, and it's going to become a sterile environment from the waist up. So be careful what you touch, and be careful when taking temperature and heart rate and respiration rate after that. So during anesthesia, we need to draw blood off of Sally. We are going to do a jugular blood draw. So we're going to gather all the equipment again. So we need a needle, syringe, alcohol, cotton, clippers, and basically we need an assistant to hold. So we are going to go to Sally and do a jugular blood draw. Okay, so Sally is right here. So for a jugular blood draw, so we're going to take off the collar, and then, so the jugs are in the neck. So what we're going to do is we're going to clip some hair. We got our catheter. We got our alcohol scrub. So we're going to take some cotton. We're going to scrub it up with some alcohol. And then, do you want to come hold his head for me? His head? Yeah. Just like that? Yep. Okay. So when doing a jugular, you got to hold off the thoracic inlet. So here's our needle and syringe. So back to what I was doing. We're going to hold off the thoracic inlet. Want to tilt his head down just a little. So I'm holding it off. Right there's the vein. So holding off, veins right here. So I'm going to go in. I'm going to aspirate a little. And then I'm going to see blood. Then I'm going to keep pulling off, keep pulling off. Okay, got enough blood. Pull out, apply pressure. Put a little Band-Aid there. And that's how you do a jugular blood draw. So we just collected blood from Sally doing a jugular blood draw. So that's pretty much done. So the surgery lasted about 30 minutes. So now we have to figure out what else needs to be done with this patient. So now that the surgery is done, we're going to remove the drape from the patient. We're going to shut off ISO, but we're going to keep Sally on oxygen for 5 minutes to flush out the ISO. And then we're going to clean the incision site from blood so we can make it look good. And then we're going to deflate the cuff and untie the ET tube. Now, you do not remove the ET tube until you get at least 3 good swallows. They have to be able to make sure that they are awake enough to the point where they don't have regurgitation. So we basically watch for 3 good swallows, or if they begin biting on the cuff, because we don't want them to break the cuff. So even though surgery is done, we still check temperature, heart rate, and respiration rate every 5 minutes, but temperature is every 15 minutes. We have to make sure that the dog's temperature is above 98 degrees before we put them back in a recovery cage. We begin stimulating the dog to try and get the dog to wake up, but we still have to maintain the 5 minutes of oxygen. We can begin stimulating by rubbing them, doing all sorts of things to get them to start waking up. So, as a anesthetist, our post-op recovery plan is to stay with the patient until extubated and sternal. We're going to continue to monitor heart rate, respiration rate, and temperature because her temp is over 98 degrees because we temped her and it was over 98. So we can get her moved into a recovery cage as soon as she wakes up. We can put a blanket in the cage along with a towel on the bottom to keep her warm, because that's important. We want to maintain the 98 degrees. And then we're going to stay with her for a while to make sure that she is actually awake and still not under, because sometimes they like to pretend that they're awake and they actually fall back asleep. So, recovery. So we would go back in a few hours after surgery is done to check on her to evaluate her pain. We would check vitals. We would take her for a walk outside if she has to go to the bathroom, just to get her up and walking. We would clean recovery cage if she went to the bathroom during this short period of time. We would give her a small amount of water so she can get back to normal habits, and we would give her half the amount of food given that she normally gets, and write down if she ate it or if she left it, and then check temp to make sure that it's still above 98 degrees. And then if she's not, stay with the patient, keep her warm. You do not want to leave her and act as if everything's going to be fine, because it's not. And then patients are to stay overnight in the recovery cage, so make sure that she has a nice clean bed, making sure that she has water for overnight. And then we would also check back on the patient 3 days after surgery to check temperature, evaluate pain, look at surgical site, and make sure she is eating and taking the meds that she needs and doing all that kind of stuff. And then the patient, Sally, can be put back into the kennel ward the day after surgery. She has to stay in there overnight, though. So the anesthesia monitoring record is something that we keep, so that goes in the patient's record. So I have completed a anesthesia record. The top part just basically says her name, which is Sally, breed Beagle Mix, age 10 months, procedure spay. She is a female intact, but now she's a female spayed, so that would get changed. It would be female spay. She's a canine, and then ASA status, she's a 1, which is normal and healthy. And then the next part is the TPR stuff. And then the next part is the pre-meds. And then the rest of the drugs, which is induction, which we only use propofol. It also states the time that we put it in. And then it's also talking about the post-op meds as well. And then this is the anesthesia. So we checked off ISO because that's the stuff that we used. It also has SIVO on it. So then we also include the rebreathing bag size and then the O2 liter per minute. So, and then down here we have system. There's non-rebreather, rebreather, and mechanical ventilation. We use the rebreathing. And then there's an IV catheter, yes. Fluid type, lactated ringers. And then the fluid rate is 114 milliliters per hour that she received. And then we also have a start time, an end time, instructor, and anesthetist. And then down here, the systems that we used manual, which means we did her heart rate by ourselves, and the pulse and all that stuff. We also used an ECG. And then recovery, we used the post-op temperature of 99 degrees Fahrenheit, so she was all set to go back. Time extubated, and then time sternal. This is all the anesthesia recovery thing. We could also include some notes like how well she did in surgery, and how well she did after, and how well her pain was, and all that sort of stuff. So now Sally is all good. She is spayed, so she can not worry about puppies.